My name is Jim Newton. I'm a consultant cardiologist from the John Radcliffe in Oxford and also the Cleveland Clinic in London. And I'm delighted to sit here with Alan Harkness, and we're going to take you through this session on echocardiography and heart muscle disease. I think this is going to be a really important and really interesting session. These are all patients who present with potentially very abnormal echocardiograms, and getting the diagnosis right is crucial. But also I'm sure we'll hear there's important points about prognosis and potentially treatment. So first up is going to be Rick Steeds. I'm sure you all know Rick, but past president of the BSE, professor of cardiovascular medicine in Birmingham. We just heard in the mitral valve talk that he regularly spends 4 hours in the cath lab doing mitral clips, so quite how he finds time to look after all the Fabry patients as well is beyond me. But over to you, Rick.
Thank you very much. First thing is, I expect most of you only came up here just because of the view, but if you didn't come up for the view and you missed it on the way out, it's really worth it. It's the place where I want to have a party, I think, as long as Jim and Alan will pay for it, that's all. So I've got an opportunity to talk about echo in Fabry disease. I can talk about Fabry disease for quite a long time and bore the pants off you. So please tell me to shut up or interrupt if you want. So I'm going to just talk through. I'm conscious that lots of people don't necessarily see patients with Fabry disease all the time, and I'm going to give you an outline that will give you an idea about what the patient is, how the patient is going to present, how Fabry affects the heart, what the processes are involved are, what the timescales of impact, because the age of the patient that you're going to do an echocardiogram is really important, and then what tests are going to be followed, and then I'm just going to give you some cases as I go through, just to give you some of the difficulties, I think, that echocardiographers face in Fabry disease. So I'm going to start. This is a case of a lady. She was a new presentation to our clinic. She's 59-year-old, central chest pain, dull, moving into her neck, lasting 5 to 10 minutes, brought on by exertion, relieved by rest. So typical angina. Past history is really interesting, and this is really common. Fibromyalgia, irritable bowel syndrome. No risk factors at 59, and she'd had 7 years of admissions to secondary and tertiary care hospitals in the West Midlands. ECG, not quite normal, non-specific ECG changes. Troponin, continuously raised. She'd had an invasive cath 3 years before, and she'd had 2 or 3 CTs showing nothing. This is her echocardiogram. Top left, parasternal long axis view, reasonable wall thickness, a bit of tuberculation on the RV side. Short axis wall thickness is about 9 or 10 millimeters. Long axis function good. Strain bottom right. All these pictures are done by Mia, who works in our department, so I have to acknowledge her brilliance because she's a far better echocardiographer than I'll ever be, but completely normal strain. So I think you probably agree that this is a normal echo. And she's 59. So the interesting thing in her, like so many people, and one of the lessons that I've learned is if we know that Fabry disease is there and you can do a relatively easy blood spot and genetic test and you know which families are involved, then surely all the centres that have got looking after patients with Fabry disease have tracked through families. And one of the things that has stunned me about Fabry disease is how many people have broken families in the UK that really are not prepared or able or feel capable of talking to their sisters or brothers to say, I've got this inherited disease and it's causing me a major problem. So on detailed family history, her brother had been diagnosed with Fabry cardiomyopathy, and this is an X-linked disease. So she was affected, but through a process called X-linked non-expression, then the presentation of this disease is extremely rare. So she's 59 and she's got typical symptoms because of perfusion defects which happen before you get morphological changes in the left ventricle. So if you do MR perfusion or PET perfusion or contrast echocardiography, you will identify perfusion defects on normal coronary angiography in these people that predates the development of hypertrophy, and even in normal longitudinal function and normal GLS. So this is a problem. One of the things that I'd like to point out as well is that this is a multi-system disease. So I find it really interesting that we quite frequently, I don't know about you, but actually increasingly we're getting referred patients who've never seen any other sort of healthcare professional face-to-face and have certainly not been examined. And actually even in cardiology clinics, you can do fairly limited examination without thinking, about why has this patient also got renal dysfunction, which is a real trigger in some cases. Why have they got funny skin rashes around their trunk? So this sort of slap cheek, funny sort of appearance of a slightly lumpy red rash you'll see around the trunk and torso, and that's important because as an echocardiographer you'll get them to take their top off. There are some other things. They do get some funny burning, which is often malattributed to fibromyalgia, and then another thing that you can put them on a stress test, and patients with Fabry disease don't sweat properly and they have a problem with anhydrosis and they just have issues like that. So cardiac symptoms are very typical in this population. Around about 60 to 70% of patients with Fabry disease will have symptoms of chest pain, palpitations or breathlessness. But actually typical examinations are often unremarkable, and knowing about the family history and the context of the patient, whether they've got a rash or whether they've got impaired renal function, is really important at the time. So, what is the disease? If it's an X-linked disease, it's a gene defect that causes a failure in an enzyme called alpha-galactosidase. As a result of the failure of alpha-galactosidase, what happens in a disease is that you get accumulation of substrate which sits within lysosomes, and that's glycosphingolipid, basically forms a sphingolipid. They're sort of a fat deposit. And if you're stupid like me, what I always assumed was, okay, this is a hypertrophic condition, and what happens is that the sphingolipid accumulates because of the failure of the enzyme, and it goes into the myocytes, and it makes the myocytes big and thick, and you get left ventricular hypertrophy, and then gradually you get more and more deposition, and the heart thickens up, and then you get diastolic dysfunction, then systolic dysfunction, then you drop down dead. And actually, sphingolipids, in severe cases, makes up less than 5% of the total myocardial mass. And the masses in Fabry patients sometimes go up to 300 to 400 grams, whereas my heart mass would probably be around about 100, 120 grams. You get deposition of the sphingolipid in the vessels as well. So one of the reasons why they get chest pain, but they have normal coronary arteries, is the arteries don't react normally. But it's not just because of infiltration. And also they get arrhythmias because there's deposition of the tissue, of the sphingolipid straight into the conduction tissue. And as always, the truth is much more complicated. And actually, once you get lysosomes filled with sphingolipid, a whole host of other things happen, so that you don't generate the same amount of energy out of the cell, that you get inflammatory processes that happen that cause premature cell death, and a whole host of and cascade of other things. But actually, you can't just do the gene and work out what the result is. So you will hear people talk about classical and non-classical versions of Fabry disease. And classical Fabry disease is really the whole multi-system disease, which tends to affect you when you're about 40. And non-classical disease tends to be cardiac disease that happens around about 20 years later. Other than that, there is no real association between genetic type and actually what the disease looks like in front of you. So that's a further complication. Plus, I think there's a whole bunch of other things that happen in these patients. For example, I'm pretty sure that once you start to get kidney disease and you get a bit of hypertrophy, that those two are accelerant and you get more of a severe disease. And that's a reflection of environmental and gene-gene interaction and organ-organ interaction in Fabry disease. So glycosphingolipid deposition causes a bunch of cellular reactions, but actually, do we know why sphingolipid then causes left ventricular hypertrophy? Nobody has the slightest idea. What does that actually mean for the patient? So this is really important for you as an echocardiographer. If somebody's saying to you that this is somebody who's 18, who's got severe left ventricular hypertrophy, and I wonder if this is Fabry disease, it's extremely unlikely that it is going to be Fabry disease. Because, to start with, the earliest signs that you can pick up in our research is that you will find small changes in global longitudinal strain before left ventricular hypertrophy. You will find small reductions in early myocardial relaxation velocity before left ventricular hypertrophy, and you will find ECG changes, which are quite non-specific before left ventricular hypertrophy. So those are really difficult, but they're the flags to pick up. You will start to pick up disease. And sadly, I'm going to show you a couple of cases because a lot of cases, because of this family dysfunctional family systems that we have, and I think probably the way that we do screening in the UK. So if you're identified as having disease in our clinic, somebody will hand you a letter saying, please will you contact your brothers and sisters and tell them I've been diagnosed with this, and if they want to be tested, then they need to go to their GP or come to us and we'll do a test after discussions about that. And that infuriates me. It tends to happen once, and actually we've got quite a lot of people who are non-white British who find it's very difficult to go and explain. Well, it's not just non-white people, but telling other people that you've got a long-standing disease is not an easy thing to do, and that they might have it too. So I can understand the failure rates in screening. So this is just onset of left ventricular hypertrophy. So if you're thinking about diagnosing left ventricular hypertrophy in men, it's usually around about 30 years, 40 years. In classical disease, non-classical disease, it can happen about 60 years. And in women, everything happens to you about 10 years later. And same thing, in men affected by Fabry disease, if you see somebody who's 60 and they don't have severe left ventricular hypertrophy, then they'll either have non-classical Fabry disease or they won't have Fabry disease at all. Because actually, I did a clinic last Tuesday. I saw a bunch of men, all aged 55, who've all got severe left ventricular hypertrophy, all releasing troponin constantly at a rate of between 800 nanograms per day, and they've all got a prognosis in about 3 to 5 years. The trouble, anyway, we won't go into that. Sorry, I'm going off the top. I told you I would waffle on because This is a classic case. 50-year-old male, 2015, presented to cardiology with palpitations. Diagnosed with recurrent persistent atrial fibrillation, had a cardioversion, was found to have a big left atrium. Found to have hypertension and comorbidity. He had also had kidney dysfunction and had had a renal transplant from a live donor. Of interest, not all kidneys are biopsied, and not everyone looks for Fabry disease on them. TT showed increased wall thickness consistently attributed to hypertension associated with renal disease. And then somebody thought, let's do an MRI and just double check. And actually that picked up that he had some mild changes on MRI, and he was picked up to have low enzyme levels consistent with Fabry disease. Referred to the metabolic service, and these are the appearances. So his LV mass is 304 grams, wall thickness 22 millimeters, and he had non-sustained VT in 2020. So about 5 years, and this is his echo. So what you can see are typical features of somebody with end-stage disease. Severe, mostly concentric left ventricular hypertrophy. Right ventricular hypertrophy occurs in hypertrophic cardiomyopathy. It's a bit more frequent in Fabry disease than it is in hypertrophic cardiomyopathy. In Fabry disease, just as in HOCM, you can get thickening and you can get mid-wall cavity obstruction and flow acceleration up to around about 3 to 3.5 meters per second in him. And he's also got chest pain as well as breathlessness, and he's got some flow acceleration. Another thing just to point out, Fabry disease goes into the valves, so it's quite common to see some mild thickening of the valve leaflets. It doesn't usually change the contractile function, and actually we've just done a registry data for the whole of the UK population, and actually requiring valve surgery in Fabry disease is really rare. So they mostly have mild regurgitant lesions, just exactly like him. Just the interesting thing that I really wanted to emphasize about this, so the problem is, with this guy, is that he's presented with severe left ventricular hypertrophy. So there are treatments for Fabry disease. The treatments are to replace the enzyme. And again, as a simple idiot, I would assume that actually, if you're short of enzyme, then you inject it in and replace the enzyme, then you start to destroy the substrate. That's great. Except that you inject the enzyme into the bloodstream, and it goes into the bloodstream, but actually you've got an intracellular problem, and you have no idea about the infiltration of the enzyme replacement into the cells. And actually, if you look at the data for enzyme replacement therapy making any difference to these patients is almost non-existent. And furthermore, that once they get advanced disease like this, they're no longer suitable for treatment. So there is a real urge to make screening effective and try to diagnose these people early. So age is important. So when you're looking at the patient, you're seeing severe LVH, think about the age of the patient, because actually If they're 20 and they've got severe LVH, you need to send them to these two. And they're not they're unlikely to be Fabry patients. But think about coexisting disease like kidney disease. Tests. So an ECG is good. I've already said that you get infiltration of sphingolipid into the ECG, and it happens very, very early. And one of the earliest changes is you get very, very short PR intervals. So you get accelerated conduction in the early stages, and then it gradually lengthens, and then by the time you're about 40 or 50, you can get PR prolongation and you can get bradyarrhythmias. So something dynamic happens in the conduction system, which is very interesting. But early PR changes is something that you can pick up in children. So you do have an idea before the onset of LVH. So there are triggers. This is another guy. This is a guy who's quite symptomatic, but he's a paramedic in the West Midlands. He's still working. And he's got wall thickness, which is 14 millimetres in the mid cavity, 12 metres in the left. Concentric, slightly increased. That's the sort of thing you're going to come up with. And the problem is, for Fabry patients, is that's a nightmare, isn't it? Because if I'm telling you that as an echocardiographer, the biggest thing that you're going to pick up is an increase in wall thickness and a change in their left ventricular mass, you're going to think about all these other things that you're going to think about before you get to it. Do they have hypertension, valvular heart disease? So the case that I showed you is classical. Well, okay, of course he's got LVH because he's got kidney dysfunction, because he's got hypertension. And actually your infiltrative causes come right down at the bottom. There are a couple of other things that you will read about. So the top is this paper by Pieroni, and you will have heard that actually in Fabry disease, one of the signs is that potentially you get this strip going down the middle of the septum that's very, very bright, and that's thought, initially was hypothesized, that actually you get sphingolipid deposition, and it's not. It's simply just interaction between the left ventricular fibers of the heart and the right ventricular fibers, and you get that strip in lots of normal people, and it's completely useless, so don't use it. It's a bit like speckling amyloid. It's complete bollocks. What I think is really interesting is on the right-hand side, and this is very interesting because I do quite a lot of work with James Moon at UCL, and he was very pleased because he published a paper about, so you get papillary muscle hypertrophy in hypertrophic cardiomyopathy and amyloid, but you get it much more in Fabry disease. For some reason, I have no idea why. So typically in Fabry disease, you get papillary muscle hypertrophy. Actually, as an echocardiographer, I find that an extremely difficult thing to think about and to measure about, but you will read about it. One thing, and it's not something you're going to measure in the echo lab, but again, it harks back to the first case that I talked about, is that if you've got somebody who's coming to you with a consistent release of troponin, chest pain and breathlessness, there's something profoundly wrong happening that's killing their cells. So actually knowing about the background and then finding a bit of left ventricular hypertrophy that's concentric really, really triggers things. So this is a sort of an ACS person, a 59-year-old, well, she's a bit mad, she's got fibromyalgia, she's got irritable bowel. She's got fibromyalgia and irritable bowel because she's got sphingolipid deposited in her bowel, and that gives you alternating diarrhea, but nobody's thought about that. So that troponin is a trigger, and it's directly related to your prognosis in Fabry disease. So clinical tests in the early stages, I'm not really being positive about the role of echo here, I think you'll notice about this, because I think this is a real difficult area. Clinical sites show real subtle signs that can be attributed to, obviously, more common diseases. So your chances to change somebody's life relies on your ability to pick up other things around the case that you're being sold as an ACS. Echo. This is just a nice paper, and it just looks at what you're usually look at. So volumes, cavity, dimensions of the EF are normal, so it's different from hypertrophic cardiomyopathy, where you usually get small cavity, hypothalamic ventricular function. You do get increased maximal wall thickness. I don't know if anyone's seen João Augusto's paper. So I was humbled to ask to measure wall thickness in a meeting by one of the fellows on the paper. And actually our ability to provide consistent measurements of wall thickness is really awful on echo. And actually what's nice is it's just as bad on MRI, because we all measure it slightly. How should you measure wall thickness? Don't ask Dr. Moody, because his answer will be completely different to Dr. Newton's. And it'll be completely different to Alan Harkness, even though he's the most obsessive compulsive, statistically correct person I've ever known about, and will moan about the diagrams for producing guidelines. Valvular heart disease does happen, but it's not common. Right ventricular hypertrophy happens in about 25%. So LVH plus RVH, a bit of valve thickening, that is a helpful trigger. I've said early detection at low E primes, so LVH plus slightly low E primes is a trigger, but the trouble is, like you and I, we often find that that can be quite variable and it's quite a subtle sign to be able to get that reproducibly. Strain is definitely helpful. So again, the picture starts to get a little bit better. This is a lovely paper by Frank Weidemann, which looks at strain as an early trigger. So we've shown it on echo and MRI. You get changes in global longitudinal strain, not in a specific pattern, although you can pick up changes in the basal infralateral wall, which tends to be affected by fibrosis. So a reduction in E prime plus a reduction in your global longitudinal strain with a particular lowering of your GLS in the infralateral wall is a real trigger for somebody with Fabry disease in the context of a bit of LVH plus a bit of RVH plus some valve thickening. CMR has a role. So one of your real purposes in echo is to say, do you know, has anyone ever even thought about Fabry disease as a possibility in this person? Because actually that really needs to trigger what has changed in the diagnosis. So we're seeing an increase in the prevalence of diagnosis of Fabry disease in the UK. And that's not because of screening, because I think our screening is still poor, but it is because we're getting better at picking it up. Because you do something called a T1 map, and the T1 map falls because you've got fat deposition in your myocardium. And that's this is pretty much the only disease that does that. So you can do one scan that takes 2 minutes. Okay, of course, an MR doctor's going to put them on the scanner and do 45 minutes of scans and other things to do. But actually, you will get a diagnosis. And that T1 happens early. There are still earlier changes in strain that you will get, but that happens before you get LVH. The other thing is, women, as always, are a bit different. Women are different from men. So men get low T1, then they get LVH, then they get late GAD, which is fibrosis, as I'm sure you know. Women have to do something different, and they get low T1 and they can get late GAD at any time, and then they get LVH at a later time. So it's different. And actually, if we're trying to treat them, don't feel stupid about flagging up this diagnosis early, because if there is any benefit of enzyme replacement therapy or oral chaperone therapy, it's early, because by the time they've got extensive late GAD, the game is over. So, this is a guy, 50s, referred to Birmingham service 2019, short of breath on exertion, couldn't manage more than 200 yards. He was a teacher, cycling to work. He'd been able to cycle 1 year before, but now couldn't. So it's a relatively rapid decline. Chest pain, dull ache, elephant on his chest. He'd been under follow-up in a hypertrophic cardiomyopathy clinic in a tertiary care centre somewhere else in the UK, and had been diagnosed after a road traffic accident, and he got LVH on a TTE first. Diagnosis was initially, is this hypertensive cardiomyopathy, is it hypertrophic cardiomyopathy, when ended up in the hypertrophic cardiomyopathy clinic. He was only diagnosed because then he got kidney disease, and the kidney biopsy was finally looked at under the microscope and confirmed Fabry deposits. And then he was referred, can we give him enzyme replacement therapy? So this is an echo. I'm putting this up, so there's a couple of things here. The first thing is, I don't think you really appreciate the degree of left ventricular hypertrophy, but you can see that the right ventricle is dilated. He's got biatrial dilatation. You can visibly see he's got poor longitudinal contraction and relaxation. I've put up the 3-chamber view. It's not great because he's a bit of a portly bloke, but he came in on, and I just think the transition between these, because this is a real message of saying, if you get views like this, you've got to use contrast, but actually we couldn't in this time because we had to call him back. But he's got some basal infralateral wall hypokinesis. Actually, when you look at his MRI, it's awful. And it really brings home that he's got a lot of left ventricular hypertrophy, and he's got an apical aneurysm. He doesn't have thrombus, but he's got severe biatrial dilatation. And he's got, so on MR images, I'm sure, as you know, on these late gadolinium, black is good, white is bad. He's just got this terrible, extensive subendocardial infiltration. And it's not infarct, he's got normal coronary arteries. So the answer is, he's 59. His first question in his first clinic was, I've got 2 teenage daughters, they're age 17, I just want to see them come through university. He died when they were in his first year, about 12 months after we referred. So by the time at 59 you've got this, and this is common for somebody with classical Fabry disease, there are no available treatments, and he couldn't have a transplant, cardiac transplant, because he'd already got a renal transplant, which was struggling. So that's one of the problems about transplantation as an exit strategy for these guys, because they've usually got multi-organ involvement. So, cardiac symptoms are non-specific, and you've got to have a really low index of suspicion. Chest pain, breathlessness, palpitations happen a lot. Sphingolipid does a whole bunch of things. We don't really know what causes it, and I'm not convinced that current therapies are very good at cardiac disease. Typically, you've got to think about the age. So from 30, men are going to have LVH, and from 40, women are going to have LVH, and that will progress, and nothing will stop it from progressing. Classical tests, you can pick it up if you're really alert on an early ECG, and you can pick it up. And actually, I think troponin is a real flag, because if you get a bit of LVH and you've got troponin, don't stop. And late disease, we can all pick up. You know, I think you'd pick this up. You might say, well, could it be a hypertrophic cardiomyopathy? We could do that, but that's an easy test. It's an easy test to do because a genetic test can sort that out. And CMR is required. Thank you very much.
Rick, thank you. Questions from the audience, please use the microphones at the side, otherwise people watching online won't be able to hear the question. Rick, I went slightly pale after your second slide, because I've seen a number of patients like that in the last couple of weeks. I mean, keeping that radar sensitivity up is the crucial thing, isn't it? And one of your graphs showed the relationship of LV mass with age. Should we be measuring mass on echo, though?
Yeah, well, I think so one of the reasons I actually wanted to put that up specifically is raised, we don't measure LV mass, do we? And actually, I'm really dubious about it, because all of the echo, so I find this staggering. Enzyme replacement therapy has been available in the UK for about 15 years. There are about 4 or 5 single-centre, 200 patient data that support that, and it's based on echo measurement of left ventricular mass. If you look at the variations on mass that you get on echocardiography, it's not accurate for the purposes of defining progression in a rare disease that happens very insidiously and slowly, like Fabry, over 1 or 2 years. And even MRI struggles with that, because MRI will vary by about 5 grams in 2 scans a year apart. I wouldn't bother to measure mass. I would think about wall thickness. And actually, if you're going to spend time, do GLS. GLS is really good, because it'll tell you. You know, the First Lady looks normal. She did have normal strain, but it wouldn't be long before her strain drops, because she's got abnormal perfusion, and that's why she's got chest pain. And that's a trigger.
Thank you. We have a question from the floor.
Brilliant talk, Rick. An audience be aware of professors who claim to be stupid when they really don't mean that. So my question relates to the chest pain, which sounds like angina.
Yeah.
And it might be due to sphingolipid deposition in microvascular disease. So do they have abnormal stress perfusion tests? And if so, DSC, MPI, or stress MRI?
So that's very interesting. So they do have abnormal stress echoes. So, you know, it goes back to the idea. It's very interesting, isn't it? I had a letter about a stress echo I'd done about 2 weeks ago, and say this person had a normal, you know, had a positive stress echo. You clearly defined apical wall motion abnormalities, and I've got normal angiogram. Can you explain yourself? And you go, well, actually, if you look at positive stress echoes with normal CAS, we know that the prognosis of those patients is not the same, and that's probably because some of these people are stuck within that cohort, aren't they? So they very clearly do. What is fascinating is that you can do it by MRI, you can do it by PET, you can do it by SPECT. They're all abnormal in Fabry disease, and you all get normal coronary angiograms. But what's interesting is that actually you get abnormal perfusion, and it's a bit like those lovely pictures that Mark Dweck shows of PET, showing aortic valve inflammation, and then 2 years later, terrible calcification, because actually the perfusion seems to track for left ventricular hypertrophy, which I find really interesting. So are we looking at a hypertrophic response to, I don't know, ischemia? Why on earth would that happen? I don't know.
But in your experience, is there a preferential ischemic or functional imaging type? I would have thought DSE, when you're looking for small patchy areas, in hypertrophied ventricles would be quite difficult. The wall motion abnormalities would be quite subtle. Maybe MPI would be...
I think an MPI would be better, or an CMR if you can get it.
Yeah.
Time for one last question, then we better move on.
So we do know the deformation imaging is fantastic in terms of sensitivity. The question is always, specificity. So my question is, do you think that there are certain indices which might be more, suggestive for fibrosis as opposed to other infiltration or even HCM, like you mentioned this infiltrator wall involvement, whether it's regional strain pattern?
So absolutely, I thank you for helping to make me to emphasize this. It's really worth it. If you've got left ventricular hypertrophy, then do GLS, and do a GLS box so you get a 17 segment model and look at the infralateral wall, because if there is location there, then you should trigger. My difficulty is that quite often you get those box plots, and at the basal segments you're not always tracking quite so well, and you don't get perfect views. But actually the answer to that is, I'm afraid, doing an MRI, because an MRI will resolve that issue.
Yeah, and a very quick second question. Do you use any diastolic deformation indices in the diagnosis, like untwist rate, untwist parameters, so diastolic strain indices?
Not in my routine clinic, and not in the patients that are going to come. So there are research uses for that, but I don't know how many people look at twist and untwist in their routine day-to-day. Chest pain patients or breathlessness, that's one of the problems. The difficulty is that you've got a disease which is increasingly common, but not everyone has been identified by genetic testing or family screening. So that the companies are right. There are significant cohorts of patients out there with Fabry disease that we haven't diagnosed. And the issue is having a low enough threshold to think about further tests to do that. And the problem is that these patients often look at 40 very similar to people like me, a bit overweight, and you've got a bit of blood pressure or something,
Thank you.
Rick, thank you. So there might be more questions afterwards. I'm sure Rick will be happy to hang around and answer questions in the lunch break.
So thank you for that, and from somewhat depressing, I think, talk on a rather rare condition to certainly something that I think is much more common and troublesome. So I'm delighted to introduce Victoria Pettemerides, who's a consultant cardiologist at Liverpool Heart and Chest Hospital, with an interest in inherited cardiac conditions and sports cardiology, which must be a challenge to get the two right, to talk on hypertrophic cardiomyopathy.
Thanks very much, and thanks to the organisers for inviting me to speak today. So I'm going to take the next 20-25 minutes or so. My slide's going to work. Doesn't look like it. Is there anyone that can help with the slides?
Yep.
She's there.
That's
Just needed to go to the presentation.
Thank you. Okay, so as I said, I'm going to take the next 20-25 minutes or so talking about the role that Echo has when it comes to looking after our patients with hypertrophic cardiomyopathy. Now, it really does have a really central role. Of course, we take a multimodality approach, particularly with the use of cardiac MRI, frequently using this to either confirm a diagnosis or give us some extra information in regards to risk and fibrosis. But Echo gives us loads of information, not only in making the diagnosis, usually the first test that will be done, if there's a suspicion or for screening, if there's a family history, or being picked up incidentally, but also we get lots of information regarding the pathophysiology and things that you see on the echo that might be responsible for an individual's symptoms. It's therefore been described as being a foundational imaging modality in a number of guidelines. You're probably all familiar with this document that was produced by the BSE a couple of years ago, and this really encourages us to take a standardized approach to our echoes in these patients. It also focuses on being very careful with the language that you're using in doing the reports, describing what we should be putting in the summary and the conclusion, but as I said, being careful with how we word things. A lot of these results are not going to go back to physicians that either have expertise or an interest in the condition. And so the report really will point the physician in the right direction as to where this patient needs to be referred. So I'm going to talk about how we use echo to make a diagnosis, how we link the pathophysiology that we see on the echo with the symptoms in terms of function, both diastolic and systolic, outflow tract obstruction and abnormalities of the mitral valve. I talk about how we use the echo to help us make some decisions regarding more invasive strategies of management, such as for septal reduction therapy, and also the crucial information that we get from the echo in helping us estimate an individual's risk of sudden cardiac death and whether they may benefit from an ICD. What I'm not going to discuss today are phenocopies. You've already heard about Fabry's and will be hearing about amyloid. I'm not going to talk about stress echo, although it does have a significant role in our patients with HCM, and I'm not going to talk about strain patterns. HCM then is just a descriptive term, really. It describes LV wall thickness, which is greater than or equal to 15 millimeters in any segment in an isolated individual, or if there's a positive family history in a first-degree member, then 13 millimeters is all that's required for a diagnosis. It's really important that we're focusing on looking or excluding any other explanation for this left ventricular wall hypertrophy. So is there a history of uncontrolled hypertension? Is there a fixed valvular stenosis? And on the echo, it would be relatively easy to see if there's a heavy calcification of the aortic valve, but looking for a subvalvular stenosis is also really important. It used to be called hypertrophic obstructive cardiomyopathy, or HOCM. We tend to reserve that now for patients that do have obstruction. Not every single patient is going to, a large proportion do, either at rest or with provocation. There's a significant subset that don't, and so we don't need to be demonstrating obstruction in order to think about a diagnosis. There are a number of underlying causes, as I said, metabolic causes that we've heard about and infiltrative causes, but a large proportion, around 60%, are caused by genetic abnormalities in the proteins of the sarcomere. Commonest one being myosin binding protein C. And this therefore leads to myocyte disarray. Instead of having normal, nicely aligned myocytes, they're all haphazard, and the patients are also prone to microvascular changes as well, with dysplasia of the intramural coronary arterioles. It's inherited in an autosomal dominant pattern, so each child of an affected individual has a 50% chance of inheriting the condition or inheriting the gene that can lead to a condition, but that does not necessarily mean that they will actually develop the phenotype. There's a significant variability in the penetrance. We think, therefore, that there's probably a 1 in 500 clinical prevalence, but more likely a 1 in 200 genetic prevalence. We're definitely looking for it more and more, and it's common already, so you're certainly going to be seeing these patients in whichever capacity you're working. The pathophysiology is complex and all interrelated. Diastolic dysfunction is present in the majority of the patients with hypertrophic cardiomyopathy. Small chambers, thick walls, stiff heart muscle, increased filling pressures. Myocardial ischemia can then occur as a result of this, as well as the oxygen supply-demand mismatch. And LVOT obstruction, of course, can contribute to further ischemia and reduced cardiac output. Some of our patients also have autonomic dysfunction, and we measure this at the time of exercise testing to see whether they're able to increase their blood pressure appropriately and make sure there's no significant drop. And that's important for us as clinicians, because that helps us give some indication as to their risk of sudden cardiac death. So when it comes to making the diagnosis, the information that we can get is from the echo. We need to, first of all, be making an assessment of both the extent and the pattern of the hypertrophy. Straight away in this case, hopefully you can see that there's asymmetrical thickening of the septum. And usually it is asymmetrical, though not 100% of the time. Measurements ought to be taken in the short axis, and that's to help us avoid any misalignment with off-axis views, and also to help with subsequent scanning. If it's not going to be, if the next scans in a patient's follow-up is not going to be performed by the same person, it's really helpful to have, or easier to have, these short-axis views to get more accurate measurements. We take them in every segment, and we take them at basal, mid, and apical level. Taking care really to avoid any overestimation of the wall thickness. So really taking care to exclude any of the RV apparatus, exclude papillary muscles. And in the short axis, as I'm sure you're all aware, it's prone to the lateral wall dropout. And so if there's any suspicion of HCM in either the referral or something that you've seen already, or apical HCM in particular, we really ought to be advocating more the use of contrast. I don't think enough of us use contrast to get the answer. And in fact, there is some data out there to show that echoes with contrast can give us accuracy akin to cardiac MRI scanning. So there are 4 anatomical variants to HCM that we'll be seeing on echo. And this is helpful for us as clinicians to understand what the potential clinical consequences are for the patient, or maybe for the patient moving forward, and also the likelihood of us detecting a gene at genetic testing. So there's the neutral form, where you get this straight septum, and this has the second highest gene prevalence. And you probably see this quite frequently in your practice. You probably see this even more frequently is the basal sigmoid septal thickening. There's some controversy as to whether this is actually a true form of HCM. It has a very, very low diagnostic yield in genetic testing. You see it in your older patients, they're lower risk. At the moment, we probably are treating it as HCM, but that may well change in the future. This form we worry about, reverse curve, tend to see this in our younger patients, very, very chunky septums. Commonly associated with detecting a genetic abnormality at testing, and associated with a higher risk of complications. And then the apical form, which can be difficult to detect at echo, really need to be making sure that we're doing all our apical views in order to avoid trying to miss this, or looking carefully at the referral. If there's a suggestion of abnormal ECG suggestive of apical HCM with infralateral T-wave inversion, again, try and think about using contrast to make sure that the apex is well looked at. This has a lower risk profile overall, and gene prevalence is not particularly high in testing. The next thing we need to look for then is any evidence of obstruction. And the underlying mechanism of this is this abnormal movement of the mitral valve towards the septum in mid to late systole. Colour Doppler will show you your high velocity at the point of septal mitral contact, and then turbulence further downstream in the outflow tract. The short axis is really nice to demonstrate this, and you can see there clearly the anterior leaflet is moving towards the septum. And then we use M mode to confirm this diagnosis, and also gives us some information as to regard to the severity, and I'll talk about that shortly. As you know, we'll be using the apical views to understand the pressure gradients generated by this obstruction. And you can see here this posteriorly directed jet of mitral regurgitation, which is associated with this systolic anterior motion of the mitral valve. It's not always posterior. More often than not, it is posterior. But if you see any other forms of mitral regurgitation, so central, eccentric, anteriorly directed, then we need to be looking at other forms of valvular disease that these patients may be prone to as well. And again, I'll come on to talk about that. The outflow tract obstruction is complicated. It's caused by an interplay between both the hemodynamic forces within this small, chunky cavity, causing a Venturian drag effect on this mitral valve leaflet towards the septum, as well as structural abnormalities that are present, so the small outflow tract. And then these patients with HCM appear to be more affected by mitral valve abnormalities, such as a long anterior mitral valve leaflet, as well as having abnormalities of the mitral valve apparatus. And in fact, some patients will have no evidence of left ventricular hypertrophy, but will have these abnormalities of the mitral valve. That's important for us to know, particularly if there's a family history, because it just gives us that extra kind of push to keep a closer eye on some of these patients. Obstruction is present in a total of around 70% of patients with HCM, a third occurring at rest and a third occurring with provocation methods. So during the test, it's really important that baseline gradients are checked both at rest and then also with your Valsalva manoeuvres, which will reduce your LV preload. You only need 30 millimeters of mercury gradient to define obstructive HCM, and greater than or equal to 50 millimeters mercury is felt to be significant enough to cause symptoms. So there's a relationship between the length of time that the mitral valve sits against the septum and the degree of obstruction that occurs. And you can see from this diagram here, it's a really nice thing to keep in your head that the mechanism is this ejection of blood, followed by this drag effect causing the obstruction, then causing leakage of the mitral valve with posteriorly directed MR. And that helps when it comes to trying to determine what Doppler trace you've got is your mitral regurgitation and what may be outflow tract obstruction, because they can frequently be contaminated. So my slides have just messed up a little bit. So grade 0 SAM, we define this as just minimal SAM, really. So often called caudal SAM, where you just see this slight movement towards the septum. And grading SAM is helpful for us when it comes to thinking about septal reduction therapy, because, as I said, there's a direct correlation between the length of time the leaflet spends against the septum and the severity of the obstruction and the gradient. Grade 1 is where you have clear systolic anterior motion of the mitral valve leaflet, but no contact with the septum. Grade 2, when there is contact, but it's less than 30% of systole. And the severest form you can get, grade 3, where it's in contact with the septum, but for greater than 30% of systole. And then we're going to take our continuous wave Doppler and assess this gradient through the outflow tract, really taking care to try and align up with the highest velocity point that you see in the LV, and using the modified Bernoulli equation to, of course, calculate the gradient. As I said, because you have this posteriorly directed MR, it can frequently contaminate the outflow tract gradient spectral Doppler trace that you've got. And so there are a few things that we can look at to try and determine which may be which. The biggest take-home message, I think, is that the MR velocity is always going to be your highest velocity. The MR envelope is usually wider, and it continues right to the end of isovolumetric relaxation, whereas the LVOT signal is much narrower and just spans the ejection time. And if you think back to the mechanism, that helps you understand why it says eject, obstruct, leak. The MR signal is helpful to think of it as similar to a mitral valve leaflet prolapse. So instead of your normal parabolic mitral regurgitation Doppler trace that you get from isovolumetric contraction right through, this begins at the start of ejection rather than at the contractions, isovolumetric contraction. And as I said, goes right the way through to isovolumetric relaxation. Whereas the LVOT signal is this late peaking, so-called dagger-shaped mid to late systolic Doppler trace. So I mentioned that the mitral valve is frequently abnormal in HCM patients with or without left ventricular hypertrophy. And these abnormalities can occur at both the leaflets or the apparatus. And it's this that can contribute in some way to the SAM, either by causing direct obstruction or just because you've got floppy long leaflets, and that's one of the commonest causes. We need to know about that, because if we're thinking about going on to treat these patients with anything other than medication to help the gradients, we need to know if we just shrink away part of their septum, are we still going to be leaving these patients with some mitral valve abnormalities, leaving them exposed to significant mitral regurgitation? And as I said earlier, it's important to look for other causes of mitral regurgitation. There's a lot of wear and tear on these valves, so they're also prone to flail valve, caudal rupture, flail leaflets, calcification, fibrosis, endocarditis, And if you see an anteriorly directed jet of mitral regurgitation, really, really take care to examine the valve thoroughly. So the commonest abnormality is anterior elongation of the anterior leaflet. And so you get this floppy mitral valve leaflet, which is sitting further into the ventricle than it would be normally. With the drag effects of the hypercontractile ventricle, this leaflet, it can flop against the septum. It's also not exposed or constrained by the same pressure gradient, so LV-LA pressure gradient, which helps with coaptation, and so this also contributes. And abnormal leaflets occur in around 50% of HCM patients. Posterior leaflet elongation can occur, although it's less common. And you can actually also get shortening of the posterior leaflet, which of course will lead to incomplete coaptation. The posterior leaflet, if it's longer than normal, will end up falling through the chordae before hitting the septum, and you can get bileaflet elongation. Abnormal papillary muscles, relatively common in around 25% of HCM patients. And we see this anterior displacement of the anterolateral papillary muscle, which means that the mitral valve is dragged towards and into the left ventricle, which means, again, it's more exposed to being able to be dragged towards the septum. Direct insertion of the anterior lateral papillary muscle can mean that there's tethering of the mitral valve, and again contributes to the abnormal motion and to SAM. But not all obstruction is outflow tract obstruction, so you really need to be looking at the left ventricle as a whole and using colour to really identify where the highest point of velocity might be. Also use your pulse wave Doppler to pulse back into the LV to identify this. You can see here on colour that there's aliasing within the mid-ventricle, and this might be related to just mid-ventricular hypertrophy, but also anomalous papillary muscles, which means that there's direct obstruction. And this isn't the same as complete obliteration of the LV cavity, and you almost need to think of it as being two separate cavities, so a basal cavity and an apical cavity. And you get this very, very, very narrowed late systolic peaking of the Doppler trace. And we need to know about that because these patients are at risk of left ventricular apical aneurysms. I don't know whether you can see it on here, but the apex is dyskinetic and thin, and there's a very small apical aneurysm. And again, there's a big role of big argument for using contrast here to really identify that. This was missed on our echo, and we only actually found it on MRI scanning. And most are actually picked up on MRI scanning. But these patients are at increased risk of both ventricular arrhythmia from the scarred, thinned apex, but also thrombus, and so they all need anticoagulation. And so it's a really important point to highlight on any of your reports. So when it comes to management of our left ventricular outflow tract obstruction, all our patients will be told to drink plenty, eat little and often, and to avoid alcohol as well as lose weight to try and help with their symptoms before starting on various medications, beta blockers, disopyramide, and soon to be some newer treatments, hopefully. But if that fails, and they still have a gradient greater than 50 millimeters of mercury with symptoms, then we need to be thinking about more advanced therapies. And the two things that we've got are alcohol septal ablation or surgical myectomy. And the American guidelines are a little bit more prescriptive than the European guidelines as to what you should be using. But generally speaking, if there's significant hypertrophy greater than sort of 30 millimeters, which you can see particularly with the reverse curve form of HCM, then alcohol septal ablation is not really going to do much to shrink that septum back. And so these patients are more likely to be offered a myectomy. If there's valve abnormalities that either need fixing anyway or are contributing to the SAM and are not going to be fixed by just shrinking back the septum, then these patients will need surgical myectomy. But if it's just the septum that you want to treat, then alcohol septal ablation can be tried. And the way we do this is with lots of planning to try and identify an appropriate septal perforator supplying this area of left ventricular hypertrophy at the septum, hopefully going from the image on the left to the image on the right, in effect causing a small heart attack and causing the septum to shrink back and creating a bigger space, reducing the drag effect and helping the mitral valve close normally. And this is just a demonstration of what we see. We use echo to guide this by initially injecting contrast down the catheter into the septal perforator that's been identified. And we plan this prior to the procedure with CT and sometimes some 3D printing to really make sure that we're accurately identifying the right area. You don't want to take too much, and you need to be careful that we're not going to take any area of tissue that might cause any conduction abnormalities. When we're injecting the contrast down, what we want to see is that the contrast not only gets the area that you want to take away, but also a little bit beyond. And we use multiple views to do this. So this obviously is just your parasternal long axis, but it's confirmed in all other views as well. And then post-procedure, immediately you will actually have, in some patients, see a significant change in the gradient. But then you can get a rebound effect where this goes up again in the couple of days post-treatment. And it takes a good sort of 3 to 6 months before you see your final result. And then this is just an overview of the surgical myectomy, which I've stolen from the Mayo Clinic website. So the surgeon will go down onto the aortic valve and will identify the area of the septum that's particularly hypertrophied. They can see this because often it's thickened and scarred and fibrosed. They'll cut it out and make sure that any mitral valve abnormalities are fixed at the same time, including sort of reorientation of the papillary muscles. This is usually TOE guided, and you can use the TOE at the end of the procedure to make sure that there's no significant residual SAM, that the gradient's resolved, and there's no obvious MR. The main thing to look for is to exclude a VSD, which we don't see so often anymore, I don't think. And also significant AR needs to be excluded from going through the aortic valve. So finally then to talk about risk. The echo information gives us a lot of data as to how we estimate an individual's risk of sudden cardiac death. Here, we use the ESC 5-year SCD risk score calculator. It's not perfect, but it does give us some guidance as to when we ought to be considering an ICD in our patients. And you'll see that the first three pieces of information are all echo data. So wall thickness, left atrial size, which should be measured in AP dimension, even though we all know that LA volume is more accurate. There's no data in HCM patients with the LA volume, so if you can quote both, that would be really helpful for us. But we put in the AP diameter for the risk score and the maximum LVOT gradient. But we also need extra information, so systolic dysfunction is important for us. These patients, generally speaking, have a supernormal or hypercontractile function. And so if we're starting to see a drop, even just towards 50%, that is considered a significant abnormality in HCM patients in terms of ejection fraction. We know that around 3 to 10% of these patients will go on to develop end-stage heart failure. And 50% will be at risk of sudden cardiac death over the next 5 years, with a mean time to death or transplant of 3 years. So although EF is not the only marker of systolic function, of course, we'll be doing our TDIs and strain patterns as well. We need to know if the EF has dropped to 50%, and that's the key number. The Americans absorb this into their decision-making as to whether somebody might need a ICD. So they use EF less than 50% and apical aneurysm. So as I've mentioned, those two pieces of extra information for us are really important. So to summarise then, I hope I've given you an overview of how we use echo to look after hypertrophic cardiomyopathy patients in terms of looking at the left ventricle, describing the wall thickness, the pattern, systolic function. I've not delved too much into diastolic function, looking to identify if there's any obstruction. Where is this obstruction? What's the mechanism? What's the extent? And is it outflow tract or mid-ventricular? And then looking at the mitral valve to see if there's any other abnormalities that could be contributing to the mitral regurgitation or contributing to the SAM. And finally, the left atrium. I've not spoken about the right ventricle at all. That's a whole subject, a whole nother talk in its own right, I think. And I just wanted to avoid it, to be honest. Thank you very much.
Thanks very much. Nice to see that simple things are still valuable, like timing for MR, and also nice to see M-board still being used. Good example of that. Just on the apical aneurysms, and as you pointed out, it's easy missed. Do you think we should do contrast in all these people, or are we going to send them for MRI anyway, so it's not important?
Yeah, it's interesting. When I was preparing the talk, it really made me reflect how little we do use contrast. Particularly in our department, it requires booking the patient in on a different list to make sure there's a clinician around to give the contrast. So I think probably moving forward, I'll probably endeavour to use it a bit more, to be honest.
Has anyone got any questions from the floor?
I think Rick's going to challenge you with a question.
It's very interesting. Do you know those valve leaflet changes and stuff? It's never occurred to me before, but it's only because I was talking about ischemic regurgitation. Do you know if those are dynamic? Are there changes in leaflet thickness length over time with hypertrophic cardiomyopathy?
I don't know, but I would say probably not, because you get a number of patients that have already got these mitral abnormalities, but they don't have a diagnosis of HCM, potentially.
Yeah, thank you. If I have just two quick questions. One is that actually when you left the talk off, so how often do you see right ventricular involvement in HCM patients, or if you see pronounced RVH, whether you would think about other pathologies like infiltrative cardiomyopathies? And the second question is probably to proceed, that's how do you change your sudden cardiac death risk assessment? Because as we know, the HCM risk calculator is not validated for Fabry's environment. So do you use any ways to predict sudden cardiac death instead of the calculator?
So RV involvement with HCM, we see it less commonly, but I think we're probably not looking for it as much as we should be. And I agree that, yes, probably they would go on to have a cardiac MRI scan to look for any other causes and to get some better imaging. Yeah. In terms of risk and Fabry's,
we're doing a multi-centre study about that right now to see, because you're not able to use the same processes. I suspect the same things apply: severe left ventricular hypertrophy, scar, non-sustained VTM monitoring. One of the problems is that when we put some randomised control trials, loop records in, we're finding an awful lot of people are having a lot of non-sustained VT in Fabry.
Watch this space. I think is what you're saying. Yeah. Thank you. We better move on to the final talk, if that's okay. So it's delighted to introduce Dr. Will Moody, who's a consultant cardiologist and director of CMR at the QE Hospital in Birmingham. And he's got the challenge of walking us through the, excuse me, the amyloid guideline. This should be really helpful, I think. How often do you look at echo and think, that looks a bit amyloidy? So this guideline is going to tell us how to actually get off the fence.
Yeah, the amyloid guideline is a work in progress, so I won't be sharing any guidelines, I'm afraid, today, but I will hopefully be able to give you a bit of insight into why it's important for you to think about amyloid in these patients when they present with left ventricular hypertrophy in your echo department. So I'm Will Moody, as has been said. I'm one of the consultant cardiologists. I have the pleasure of working with Prof. Steeds. He's already given you some insight into myocardial speckling, and I'll talk to you a bit about that myself. My views are my own. So I've got 20 minutes or so to go through the following. I'm going to talk to you a little bit about amyloid itself, because I'm conscious that not all of you will be familiar with these patients. So the main subtypes that affect the heart, there are two. I'm going to talk to you about why it's important, and ultimately that's because it's far more common than we first thought. And I'm going to take you through the non-biopsy diagnostic algorithm that we use in our everyday practice, and the importance of echo. And I'll tell you up front now, I enjoy CMR, but you don't need a cardiac MRI necessarily to diagnose cardiac amyloid. I'm going to talk to you, of course, about the classical echo features, and I'm going to try and dispel some myths. So there are a lot of historical misconceptions about what amyloid looks like in the heart, and I think not all of it is true. And if I've got time, I'll show you a few cases that we've learned from. So amyloidosis is not a single disease entity. In fact, it refers to a collection of diseases. It's a disease of protein misfolding. And what happens is the protein infiltrate deposits as beta-pleated sheets, and you might remember from your undergraduate days that those have a special apple green birefringence under polarized light on histology. But for the purposes of today's talk and this audience, more than 95% of all amyloid that affects the heart are one of these first two. And we subtype amyloid on the basis of the protein that's involved and that's laid down as the amyloid fibrils. So the first of those is cardiac AL, L for light chain. So that's when you've got a patient in front of you with a monoclonal dyscrasia or a bone marrow abnormality in simple terms. And the monoclonal protein is the immunoglobulin. So those patients can range from having a simple, what's felt to be fairly straightforward MGUS in elderly patients, so monoclonal gammopathy of unknown significance, right the way through to patients presenting with multiple myeloma. And then really the reason I'm here is because of the surge in interest in transthyretin amyloidosis. So again, that can be broken down into two forms. Transthyretin is a protein that we all produce in our liver, synthesized in the liver, it's secreted into the serum, and it's involved in normal health in binding retinal, and it's involved in the CSF, but also binds thyroxine. And there are two main forms. So there's wild-type ATTR, which used to be known as CNAR. Thankfully, patients aren't no longer termed as CNAR, which they're glad to hear. And there's the hereditary form, of which there are two relatively common variants in the UK that you should be aware of. So the V122I, which is carried by about 3 to 4% of all Afro-Caribbeans. And we have quite a large Jamaican population in Birmingham, so we come across a fair bit. And also the T60A, so that's more common in Irish Caucasians. And I'm not going to dwell on any other forms because I think you'd be unlucky to come across those. So how common really is this condition? Well, the truth is that no one knows yet. But what this graph shows you quite nicely is that there's been a real upsurge in the number of diagnoses made. So this is just transthyretin amyloid cardiomyopathy. And these data are quite old now, taken from the NAC, the Royal Free, up to 2016. But I can tell you on the basis of our service that that exponential rise, if I just grab my laser pointer here, continues. And certainly we've seen referrals of around 350 patients in the last 2 or 3 years. And actually the vast majority of our cardiologists that are sending these patients are pretty switched on. And well over half of those have turned out to have cardiac amyloid. The proportion of patients with hereditary, again, probably for reasons like Rick's already alluded to in Fabry's, hasn't yet really, we haven't seen that upsurge, and that probably relates to difficulties in screening these patients and resources involved. So this is a hot off the press meta-analysis from Claudia Rapezzi's group, and I think it gives you quite a nice summary in terms of what to look out for and having this in the back of your mind. So we've heard about hypertrophic cardiomyopathy, and this was a study that involved 31, no less than 31 screening studies, but of those, there were 2 or 3 that were involved in hypertrophic cardiomyopathy. So these were patients referred to a tertiary centre with an initial diagnosis of hypertrophic cardiomyopathy and then were subsequently diagnosed following DPD scintigraphy with ATTR cardiac amyloid, so beware. A lot's talked about aortic stenosis, and I'll talk to you about that in a second. What about in patients, in unselected elderly patients on autopsy? So as many as 1 in 5 patients over the age of 85, if you look in their hearts, they will have evidence of amyloid on histology. Now, the significance of that is unclear because not all of those patients were necessarily symptomatic, but it tells you it's a common disease, particularly in elderly white males. And just the HFpEF population, again, massive population of patients. And this is mainly registry work that's come out from Spain. But again, if that's really the truth, then there's an awful lot of these patients sat in your heart failure clinics. So data from Tom Tribal, which has been replicated by other centres, Tom Tribal's work and Paul Scully from Barts, showing you that there's a clear association between severe aortic stenosis and patients that are referred for TAVI or open AVR and this condition. And the numbers are as high as 1 in 7, 1 in 8 patients. So again, it's something to be aware of if you're not aware. Now, I can't do a talk on amyloid, unfortunately, without showing you this slide, which is really, it's quite an old slide, but really the reason I need to show you this is because this is really how we base our clinical practice. It was a paper published now some years ago, Julian Gilmore's group, and it's a busy slide. For that I apologise, but focus down this right-hand side, because the vast majority of patients do no longer need a tissue diagnosis to make a diagnosis of ATTR cardiac amyloid. So if you follow these simple rules, and something that's worth highlighting, as I said right at the start of my talk, is the and/or. So for the echocardiographers in the room, they often get chastised and said, oh, you need a CMR. Well, actually, it's nice to have a CMR. Don't get me wrong. You can quantify extracellular volume, which correlates very nicely with amyloid burden. But actually, if you've got a characteristic echo with a patient presenting with signs of right heart failure, a DPD scan, so this is bone scintigraphy, with grade 2 or 3, so good going myocardial uptake relative to the ribs, then you can come down this side of your algorithm. And you don't need, so long as you do this, and I must stress this is really important, so you do need to form a monoclonal dyscrasia screen, and that needs to be normal. So in the absence of a monoclonal protein in urine or blood, with a normal serum-free kappa lambda, then you can come down this side of the algorithm. And we would recommend genotyping in all patients. We've been caught out with some elderly patients having variants. So I often get asked that question at the end of my talks. Do you really need to genotype all these patients? The answer is yes. So 3 steps in diagnosing cardiac amyloid, which is the most important? Well, you're never going to get to a diagnosis unless you suspect up front. So that's where you guys come in. So if patients present with heart failure and have a disproportionately elevated NT-proBNP, even via their GP, they'll be referred for an echo. And it's not always quite as straightforward as this. This is a pretty striking example in a patient that probably has ATTR on the basis of the degree of wall thickening, but you can't be sure of that, and I'll talk more about that in a minute. But what's clear is that you have significant LV thickening, left atrial dilatation, there's a small pericardial effusion. I've already talked about aortic stenosis. There's a degree of restriction in this aortic valve, and even the mitral valve is thickened. So again, that's worth taking home. This patient does look to have concentric remodeling. If you look at the TDIs, these patients will all have diastolic dysfunction early. They'll have elevated filling pressures with raised E over E prime, biatrial dilatation, and in essence, they have a restrictive cardiomyopathy. And strain, I think it's easy to do now. It's far easier than it was when I was doing my PhD more years ago than I would like to confess. And we can now just, with the sake of a button click, generate a GLS, and that's really important, and I'll tell you why. So out of interest, because I'm in the process of trying to write some guidelines, I have had a look at what's out there already, conscious of reinventing the wheel. But it's interesting that the Americans comment on a couple of things. So it's only recommended, but not mandated, to perform longitudinal strain, which I think is controversial, if I'm being kind. And we've already heard about Prof. Steeds' opinion around myocardial echogenicity. So the first myth, amyloid is the only cause of granular sparkling. Now, if I turn up the gain and using harmonic imaging in all of you in this room, I can create speckling. So I think it's fair to say that the Birmingham opinion, at least, on myocardial speckling is that this isn't a helpful tool. And there are some studies. Note how old these studies are. When this became a thing, it was back in the 80s, and we've moved on since then. It's not specific. So, yes, a quarter of patients with amyloid, but also patients with hypertrophic cardiomyopathy, end-stage renal disease, Pompe hypertension, hemochromatosis. So it's not terribly helpful. In my personal opinion, and it is my personal opinion, I think the term should probably be consigned to history. Now, this is a CMR paper, I must admit, and I've got an echo here. So most patients, as I've said, well, a significant proportion of patients are felt to have concentric remodeling, but again, this is rubbish. So patients with wild-type ATTR cardiac amyloidosis will often have asymmetric septal wall thickening, and this is data that's been borne out from the CMR community, but it's the same in echo. So in this paper, this was a relatively small paper, and only 51 patients, less than half had concentric remodeling, but the majority had asymmetric wall thickening. And this is a really nice paper that just backed that up some years later in a much bigger cohort, again, data from the Royal Free this time. And they've shown that you could be forgiven particularly this is what really worries me. So for the cardiologists amongst you that are interested in hypertrophic cardiomyopathy, this is the sort of thing that makes Dr. Bradlow sweat a bit when I show this slide, because this is reverse contour, and we've heard about that in the last talk. If it wasn't for these PSIR imaging here, which gives the game away, there's only one thing that does this, and that's amyloid. But if you saw this on echo, you could be forgiven for suggesting the patient has hypertrophic cardiomyopathy. That's not your job. I think your job is to highlight that there's abnormal hypertrophy and raise the suspicion of amyloid and or HOCM. And again, that sort of reflects on that, perhaps on that registry screening study that I talked about earlier. The final myth I want to dispel is this. So amyloid often only gets thought of as being a disease that involves the myocardium. And that's the most striking abnormality we see. But there are increasing data now to support that amyloid also affects valves. And this was a beautiful paper, again, coming from the Royal Free. And this was big numbers of patients that had had baseline 12-month and then 24-month prospective echocardiographic evaluation. And of all the parameters that they looked at, and there were quite a few, I can tell you, the only thing that came out in terms of predicting prognosis was the degree of worsening mitral and tricuspid regurgitation. So we know that mitral regurgitation is bad for people in general. It's particularly bad in patients with heart failure, and the same is true for amyloid. And with the histology, they were able to show quite beautifully that amyloid infiltrates the valves. So these valves are not just getting secondary MR, there probably is a primary element to this. What about strain? Well, I'm a big proponent of strain, and I think anyone that presents with left ventricular hypertrophy should have longitudinal strain analysis as part of their standard workup. And I don't think it takes too long anymore, so we should be able to do this. It's not always this clear, but this is a nice example from the Cleveland Clinic. So these top 4 patients have all got amyloid, and you can see they've got that classical apical sparing with preservation of strain at the apex. Conversely, in these 2 patients with hypertrophic cardiomyopathy, who happen to have asymmetric septal wall thickening, their strain's reduced in the areas of maximal hypertrophy. And these are 2 patients with aortic stenosis with a more variable strain pattern. But I think it is useful. More data from the NAC. So this was led by Dan Knight. This was a cross-sectional study involving 300 patients. And what I really like about this is that they've correlated both echo and CMR and looked at the interrelation between those 2 variables. So I've talked a bit about extracellular volume. That's something that you can do with the pre and post-contrast CMR. I don't want to dwell on this as this is not a CMR audience. But what it does do very nicely is it quantifies amyloid burden, so the degree of amyloid filtration. So if you've got an ECV, usually of more than 45%, you've got a much worse prognosis with amyloid. But at very early stages of the disease, you'll see that echo is really, really good at picking up as an early marker of abnormality in these patients. So again, E over E prime and strain being the early markers. In terms of prognostic data from this study, it was CMR-derived TAPSE, but there's no reason why echo shouldn't too. And stroke volume index, and I think there's a lot that's been said about stroke volume, and these patients struggle with low stroke volume states. Again, massive study, more than 1,000 patients enrolled in this, and this is showing you that echo really can, it can live up to CMR in terms of echocardiographic prognostication. So there's an interesting interrelationship between systolic parameters and also diastolic parameters. But what came out from this study, these were the main markers that were of interest, and these were all independently prognostic. Just to show you strain as an example, with a binary cutoff of less than 10%, we showed pretty impressive discrimination in terms of adverse prognosis in these patients out to 5 years. So not only is strain useful for diagnosis, but I think it also adds prognostic information that's important. So in terms of the relative role of cardiovascular imaging, I think it's fair to say that imaging is important in diagnosing the patients. I made a comment earlier about sometimes what really makes me boil my bug, sometimes it gets me rather irate, is when I see reports around whether or not, based on imaging, the patient has AL or ATTR. It's true to say that patients with ATTR tend to have greater LV remodeling in terms of greater LV thickening, but it's really dangerous to lead clinicians down that route. And I would urge caution about trying to diagnose tissue, subtyping of amyloid on the basis of imaging appearances. Our job is just to raise a suspicion of amyloid. And it's your DPD scintigraphy and your monoclonal dyscrasia screen that will determine what form of amyloid you have, potentially rarely needing a biopsy. In terms of CMR, though, there's no doubt that CMR has been used, and where it really benefits us is in terms of extracellular volume quantification I've talked about, and it has a very characteristic gadolinium uptake pattern with abnormal gadolinium kinetics. So it makes our life easier. But I can't stress the importance of bone scintigraphy. Scintigraphy has been a fantastic test, and it's a really, really specific test for cardiac amyloid. Again, it doesn't rule out ATTR versus AL, but if you've got uptake in the heart on bone scintigraphy, there's very little else that can cause that, with the exception of perhaps a massive heart attack within the last 2 weeks. So quickly, some cases if we've got time. So Rick won't mind me showing this, because I think it's a lesson that we learn from this, which I want to share with the rest of the audience. So this was a 79-year-old male presenting with angina, had risk factors for coronary disease. There was a history of paroxysmal AF. A lot of these patients will be in AF, which is always a nightmare when you come to echo them. Often they'll have conduction disturbance. ECG here showed first-degree AV block with a left axis deviation and a left bundle. Again, we've heard about the importance of troponin. So persistently elevated biomarkers is a real red flag for any myocardial process, whether it be Fabry's, HCM, or amyloid. It won't discriminate, but you'll see disproportionate increases. Patient went for coronary angiography, only had mild atheroma, but they had an echo. And a lot of these patients will have a low cardiac output with a low stroke volume state. So often there's a danger on transthoracic imaging of underestimating true severity of AS. In this patient, we were alerted to the calcified aortic valve. So the patient underwent a TOE, and they fulfilled criteria that was consistent for severe low flow, low gradient AS. To make doubly sure, we did a calcium score which supported that. Now, the problem was this patient hadn't yet been diagnosed with amyloid. So they were discussed in MDT, went forward and had a conventional open heart surgery. And I can tell you that the post-op course for this patient was particularly stormy. They struggled to get them off bypass. They were on ITU for a period of 2 or 3 weeks following. This is going back to 2017, when I knew much less about amyloid than I do now, but it's an important lesson. So back in clinic, 6 months later, NT-proBNP still significantly elevated and troponin up, and the penny dropped. So I had a DPD scan and showed evidence of amyloid. So I think the lesson here is these patients don't enjoy going on bypass. Similar case. So coronary disease is common. These patients are often elderly and male. Exertional chest pain patient, classic angina, and I was luckily in the cardiothoracic MDT. So this patient was was going to be listed for bypass, but luckily they put their echo up, and I put my hand up and said, I think we just need to be sure. So not relatively subtle. There's, you don't see the lateral wall terribly well, but again, I think there's probably asymmetric increase in LV wall thickness here. Some interatrial septal thickening, not much of an effusion, but nonetheless enough concern. So we did raise the possibility of this being a restrictive cardiomyopathy. And we did a DPD which showed grade 2 uptake, and the diagnosis was made. He did go down actually to the NAC, had a stress CMR, which was interesting. We've talked about perfusion abnormalities, and certainly these patients also have perfusion abnormalities that was out of keeping really with the patient's disease, just confined to the LAD. After much discussion, it was agreed that he would be much better served with complex PCI procedure to the LAD, and he had that 3 years ago. Was put on tafamidis and is still doing amazingly well. So I think we made the right decision. Lastly, last case in point is just beware of left atrial thrombus. So even in patients with sinus rhythm, in these patients, they have very low flow states, particularly in the left atrium, often have spontaneous echo contrast. This was a patient who was in paroxysmal AF actually, and persistent AF, who'd gone into AF recently and had become very symptomatic. So we were keen to explore the possibility of DC cardioversion. Despite a long period of anticoagulation, there was left atrial thrombus in the left atrial appendage. So beware of cardioverting these patients. And we can have a discussion about whether they benefit from cardioversion perhaps at the end. Take-home message. I think what I've hopefully made clear is that this is not a rare condition. It's out there if you look for it. It's worth looking for it because there are treatments on the horizon. And again, I haven't had time to cover treatments today, but we can discuss that perhaps at the end. I think where our role is as an echo community is to raise the suspicion. Nobody's going to accuse you of getting it wrong if you raise the possibility of amyloid. But what we don't want to see is a patient who comes back 3 years later with a really good going case of amyloid, because when it's all too late and there's no option to treat those patients. Strain, I think, is really helpful, and I think should be performed in all patients with left ventricular hypertrophy, not just in patients who are worried about amyloid. And I think it's worth stressing that the job you do also provides prognostic information as well as diagnostic information. Thanks very much for listening.
Well, thank you very much. That was a very clear walk through what we should be looking for and how we suspect amyloid. Questions from the floor? I've got one question just to kick off. I was struck by the 2% pickup rate when screening conduction disease. And these patients have spectacularly abnormal left ventricles, but don't seem to run into trouble with VT and arrhythmias. Can you shed any insight as to why that's the case?
Yeah, we do. So I think there are two groups. So there's the ATTR groups and there's the AL. I think the AL are a nightmare. I don't like suggesting putting defibrillators into any AL patients. AL, I should stress, is a very different condition. So those patients have a much worse survival, even with chemotherapy, median survival with good going stage 3 AL amyloid. Median survival is around 6 months. It's pretty awful. So those patients do get non-sustained VT, and we have ongoing debates about whether they should sit on our telemetry bed, which is all too precious in cardiology, to have Velcade given to them and then review whether they have any non-sustained VT. What are you going to do if you see it anyway? I think for the ATTR patients, we do have a low threshold to put pacemakers in these patients. When we have had to put pacemakers in, it's usually because of severe chronotropic incompetence. So I've talked to you about the importance of low stroke volume. I think also they have a difficulty to increase their heart rates. And so often we will exercise our patients, rightly or wrongly, with exercise echo. And that can be helpful to see whether they're limited, mainly because of diastolic dysfunction restriction, or whether it's chronotropic element. When we do pace patients, so I work closely with Prof. Laver, and because these patients often become pacing dependent very early on, we tend to put an LV lead in those patients, but again, it's an evidence-free zone at the moment.
I'm afraid I didn't see you won the foot race to the microphone, but no.
That's a great question. And there is one abstract that I'm aware of, which is picked up on this, published in the US. I don't know if that's what you're referring to, but I know it's small numbers of patients, but you're quite right. There's probably amyloid infiltration. So I listened to Mark Dweck on Wednesday at BSEcho, and he talked to us about the importance of calcification in these valves. And there's no doubt that they probably have calcification. But I suspect there is a subset that are getting amyloid infiltration, which is contributing to their AS. So whether the calcium scores, same cutoffs can apply, I suspect not. My feeling is that if they're limited and they're breathless, I mean, what we know from Tom Tribal's data and Paul Scully's data is that it's not, their AS probably dictates their prognosis. And certainly if you think they're going to survive more than 12 months, I think it's still reasonable to go ahead and intervene on their valves. But yeah, great question, and I don't have a clear answer to that.
Tim Fairburn at that meeting actually said that he had looked into the data in Liverpool and said that 10% of their population with low gradient, low flow had low calcium scores, but had done 3Ds and identified true to what he said, true severe AS. So I think it's very interesting. Mark's response to that was actually you don't use the calcium score, you use the degree of fibrosis on the valve on CT. But,
Yeah, I mean, we've got into debates with women as well, where I don't know, you know, there's been some great data from Tanya Pawade's group with Mark around CT calcium scores in AS. I've often got into debates with our colleagues around females that haven't met criteria for AS, low flow, low gradient AS, and I think there's work to be done in that area. It's sex dependent too.
Last question from Nav, and then we'll let you off for lunch.
Great talk. I now understand after Rick's talk why patients with Fabry's don't have small ECG complexes. So this is a really old man question. Is amyloid still the only LVH variant which causes small complexes on ECGs? And your AF ECGs, the only ECG you showed, the limb leads were small complexes. V leads a little bit bigger.
Yeah.
Is it still a truism, or is it a myth, or what Rick would call bollocks?
So I'm glad you raised the ECG, because I think, again, it's one of the misconceptions. It's not an echocardiographic myth, but there are myths. So we're all taught in med school, as you say, that low voltage complex, think amyloid. The truth is that it doesn't rule out ATTR. So I've got a number of patients with ATTR cardiac amyloid who have ECG left ventricular hypertrophy on their ECG, and they still have amyloid. I think it is applicable more to AL. It's not totally sensitive or specific. The reason is, without wishing to go into too much detail, but there is a great paper from Mariana that's looked into this. AL, the light chain, is far more toxic to myocytes, so you actually get myocyte destruction. So we all know, I think I mentioned, hopefully if I didn't, I should have, these patients really have pseudo-hypertrophy. So you're not seeing myocyte hypertrophy, and in AL, the myocytes, if anything, get smaller because you affect, and that's been borne out with ECV and other, and some elegant CMR work. So I hope that's answered your question. So you don't see myocyte hypertrophy to the same degree, but you often will see ECG LVH.
So it's still abnormal protein deposition.
Yeah. Oh yeah. But it is worth saying that, yeah, don't discount amyloid on the basis of ECG alone. It's not a rule-out test.
Great, thank you. So take-home messages: measure wall thickness carefully, don't bother with mass, look at the mitral valve apparatus in HOCM, and do strain.
Good summary.
Okay.
Good job.